Hello, everyone. Welcome. Give people a minute or two to get connected, and then we'll get started in a good way in just a moment. Okay. Thanks so much for joining us today. We're very excited to have a panel here to talk about peer recovery. I'm going to do a little bit of introductory information about our center really quickly. So we are a tour technical assistance center. So we are here to support tour grantees with any issues or questions or things you might need to help you get through your grant and to meet all of your requirements. So please reach out to us anytime if you have questions or would like assistance with anything. We are funded by SAMHSA. We are also part of the National American Indian and Alaska Native Technology Transfer Center, and we're located at the University of Iowa. As I said, we are funded by SAMHSA, and the content of today's event is developed by the presenters or the panelists, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. Following today's event, we will send up a follow-up email, which will include links to the presentation slides and recording, if applicable, and information about how to request and receive CEUs, and the link to our evaluation survey. The survey is very important for our center and our funders to ensure that our events are beneficial to those who attend. So your participation is voluntary, but we would really appreciate you taking a few minutes to help us by completing this survey. You can skip any questions that you do not want to answer, and all responses will be kept confidential and cannot be linked to you. So please reach out to me or any of our other staff members if you have any questions about that. Although we are gathered today virtually, we want to take time to acknowledge the land and pay respect to the Indigenous nations whose homelands were forcibly taken and inhabited. So please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Kaylee Driscoll and Sean Bear. And lastly, I do have our survey up here on the screen, but we'll also share this in the chat. So we just wanted to once again take a moment to thank you all for attending, and that we would love to hear what you think about today's event. So please take a moment before you go to click on that link or click on it in the follow-up email that you get, and let us know what you thought of today's event. We'd really appreciate it. With that, I want to welcome our panel. I didn't introduce myself. My name is Kate Trams, but I'm also here with my team members, Noah Siegel, Kathy Tomlin, Sergey Deptula, and Shirley Kane. And Shirley and Kathy were instrumental in putting together this panel. And I believe, Shirley, would you like to introduce the panel and get things started?
You bet. Good afternoon, everybody. Welcome to the webinar on peer recovery. Also, I want to acknowledge Colin in his smudging. Although I'm not there. Oh, my glitch. I can kind of smell it. So I just love medicines, and it's, oh, Jared too. Me glitch for the medicines. It's just, those are very powerful and very helpful, especially, you know, when you talk about the work that everybody does. Everybody needs to have something or some procedure or some way to help themselves, take care of themselves throughout this process, because this is very unusual times we're living in right now. So miigwech for those prayers, Jared, and miigwech to Colin for burning the medicines, and Jared too. I just have to say this as a preface. We did a really interesting meeting, in the planning, and when the peers that are presenting today, when they met each other, it was to me, it was a spiritual process, and I really want to acknowledge that process, because to me there was like some powerful things that happened even during that meeting, and I know that more powerful things will happen. So we have the tools and the support of each other that we all need during these times to do this work, and to be there for our people in a good way, to always be there for our people, and to live those values that our ancestors have passed down to us. So the peer recovery panel is Jared Murray. You've already met him. He said the blessing, and I'll let him introduce himself and tell us a little bit more about himself, and then we can go one by one with the panel members. So Jared, you first.
Hey, thank you, Shirley, for your amazing lead, and just, listening to you talk, it just makes me feel like, I'm back home with, and listening to my elders. And I hope I didn't age you or whatever, how to say it like that, but it just felt that energy felt really good. So I just kind of want to acknowledge that. Thank you. I'm Jared. I'm the executive director of Painted Horse Recovery. I'm in long-term recovery. 10/19/12 is my clean date. So I got a couple months in there, so. But basically, just to what we do here at Painted Horse, it's a recovery community organization, and it's peer-led, it's mentor-led. So we offer mentor services, right? And basically, so we'll have NA meetings, AA meetings, but in a native way. We have Wellbriety, we have those places, and those are open altar meetings, so everybody, every color of the medicine wheel is welcome to sit in on those. But we live in Portland, which is kind of like the hub around. So there's like 9 tribes around Portland, right? And different people come in and they get out of prison, or they go to treatment. And after treatment, what we do is we're like that continuum of care. We offer that safe place for them to bring their culture in, and so we have longhouse people that are longhouse people. So they're able to do that. We have people that are NAC, Native American Church people. So we give them that safe place to practice for their drum tie and their water drum. So those, are up to the leaders that started those, those meetings. It's up to them to what that looks like as far as closed altar or open altar, and letting other people in. The beautiful thing about a community organization, and the community organization that we've built, it's culturally specific for Natives. So our elders, our women elders are leading this movement, and so our board of directors is Native through and through. And we've been really successful with hiring Native preference staff, and all of our staff is Native as well. And also, those that we serve is the Native community. So I think that's a good thing about, a recovery community organization. It's the community, it's our elders, they're leading the movement. We don't have people from clinical or hierarchies, not saying that clinical is bad, clinical is good. A lot of people go to treatment and then get out afterwards, but, it leaves it to the community and our elders to run this in this way, and the way they see fit, more traditional way. They don't have somebody telling them, hey, you need to do this, and that's how you need to do it for this. And so as a community organization, we don't bill Medicaid, we don't run groups. What we do is we get our funding from the state, and we're able to just offer those services, a place to be. Come reconnect to your culture if you got lost, or if you went to prison, or through drugs you got off that road. Come reconnect, come sit with us, come be with us. And you don't need to be in mentor services to just be in a safe place for Native Americans, right? I mean, we encourage people doing the intakes and getting a mentor, but we also encourage unity and culture and love and stuff like that. So, it's just been a really big journey. If it wasn't for Eric Martin and Deborah Buffalo Boy and Tony Bazina, I wouldn't even be able to be where I'm at today. And this vision came together with my elders and with me. And it's an honor to just even be asked to sit in this on this panel, to sit in this circle, and to be able to serve our people, right? That's the word, be of service and serve. Like a lot of times, like if you hear politicians, they'll use the words help, and it just sounds like a Band-Aid or something that they're gonna do or say they're gonna do, and I think when it's of service, and you're of service of your Native people, and you're of service of all people, you're just of service, that's the true healing, and that's that true connection. And like, so the spiritual dollars are in full. The bank account with spiritual dollars is full, I guess. And I see Colin smiling because in agreement, because I really feel like when we create safe places for our people, we're able to serve them, we're able to help them grow and reconnect with who they are, or if they find that connection on their own. As long as we offer a safe place to just be you, that's good. So basically I don't know if I'm running past my time or
Just a little bit.
Okay. Us, that's the thing to us natives too. Man, I could just talk for 2 hours, and I wanted to pray for those wingeds and those grasshoppers and that water we drink in the morning. I will offer prayers for that. And tobacco for all you listening. Hey, no, okay, I'm going to stop, but thank you guys.
Okay, very good, Jared. Okay, Annette, you can go next.
Hi, everybody. My name's Annette. I reside in Alaska. And thanks, Shirley, for hosting this panel. Just so you know, Jared and I had like a whole conversation the other day, probably for like 30 minutes before we were doing a planning session. So yeah, Jared and I can talk. My recovery date is March 6th of 2009. My recovery has changed over the course of my days in recovery. And what my recovery looks like today is that I no longer engage in harmful substances, people, relationships, ideas, things that are harmful to me. But it's taken me a lot of growth and a lot of work to get there. I work as a medication for addiction treatment intake case manager. I live in a small town, so I'm kind of a jack of all trades kind of thing. And we run our program through our primary care. And it's really taken us, we're still developing what our MAT services look like. But for now, it's really through our primary care with referrals to behavioral health. We're all housed in under one umbrella. I do work for my tribe. I'm a tribal member for the Ninilchik Traditional Council in the village, and I reside in Ninilchik. And I got it into this work. Well, I was handed it to me, but it wasn't really something that I wanted to do. I didn't want to work in recovery. I've worked in behavioral health for a long time. Hi, Heidi. Heidi and I went to school together. Anyway, so sorry. But this was not something that I wanted to do, period, end of story. And I started doing this work and was very reminded about my own story. And my own story is that I took medications to assist me in my recovery. And the peers that I remember in my recovery feeling very stigmatized, and like I couldn't talk about my own mental health or the fact that I was taking medications to assist me in my recovery. The fact that I was taking antidepressants or anything like that in my early days of recovery. And so now when I am working with patients, my role as a peer is to talk about that with patients in the clinic, right? As a case manager during their intakes, I lay it all out on the table, like all of that stuff. And those conversations are really helpful. My primary role is not a peer support. I don't bill for peer support, but I take the language and my story, and I use it to help people to get services where, they're ashamed of all of the things that they have done. And I just lay it out there. And I mean, I've told patients, like, the only reason that I have quit doing the things that I have done is because I punched my boyfriend one night, period, and they're just like, well, I'm just here because I don't want to overdose anymore. And I'm like, great, let's start. Because we all have to start somewhere. And so I have found that, when we share those shameful parts of our stories with people, that's where the healing can start and the journey can begin. And the other thing that I also do is, patients really have a hard time with trying to access MET. So I also do work at our local syringe exchange. And by being there and doing outreach and talking with people who are still actively using and providing them with the education and the language to empower them to access treatment, or providing them with education about what buprenorphine or the difference between buprenorphine and naltrexone, long acting, short acting, the benefits and the harms, and why you need to, have naloxone, and safe injection practices and all of these things. Or also connecting active users to other active users about safety and injection and smoke, like all of these things. It just helps people just make safer decisions. So I'm not ashamed to ever share my story with people, and helping people define what their recovery looks like. And it has really it's been a really awesome experience.
Awesome. Okay. And I'm going to remind the rest of the next two, this is an introduction. Most of you are going right into your spiel. So into your little things that you have planned. But that's okay. So Colin, you can go next.
Oh, bonjour everybody. Ni Tamigabo and Dishnikas, Magizi Dude, Mrs. Aigani and Dunjaba. My name is Colin Cash. I am from the Mille Lacs Band of Ojibwe, Eagle Clan, and I am currently a grant development specialist for the Mille Lacs Band here. But what led me to this role, I guess, was a lot of the work that I've done in the community around recovery. There wasn't a whole lot of people to lean on for support. When I got into recovery, I've been abstinent since December 18th of 2015, and I'm recovering from IV drug use. And there wasn't a lot of support. And I did a lot of work in the community to build them supports and work with a lot of people and draw on resources that are in the area, and created a network that now spans 5 different states and 20 some different chapters of Sober Squad that are emerging on other reservations. And so I've done a lot of work in the community around recovery, around advocacy, support, and I was a certified peer recovery support specialist for a couple years, and then I train peer recovery support specialist through Minnesota Recovery Connection. Little side gig I got besides this, what I do here. So recovery is definitely a part of my story. My community is definitely a part of my story. And I just want to be of service and help other people that are been in situations similar to mine.
Okay, Miigwech. Eric, where are you?
Hi, I'm Eric Martin, and I work for MACBO, the Mental Health and Addiction Certification Board of Oregon, and we certify peers. I'm also a person in long-term recovery. I got clean July 7, 1985, and I've been working in behavioral health for the last 30 plus years. And we also operate a technical assistance center for peer programs. And Jared mentioned RCOs, community recovery organizations, recovery community organizations. And there are really two types of those. There are recovery community organizations that provide peer services in the community. And then there are recovery community organizations that also operate recovery community centers. And these are sort of like drop-in centers, places where meetings like 12-step meetings and Wellbriety occur. And so we do technical assistance and best practice trainings for staff that work in recovery community organizations and recovery community centers. And there we go. That's my introduction. Thank you.
Nice. Well, thank you, everybody. Before we go any further, I just want to acknowledge the other people that are here that are part of our network as well. Will Longinetti, he's from SAMHSA. What, Will?
Hello, everyone. Good afternoon. It's good to see you all. Thanks for the introduction. And yeah, along with me, I have two other project officers, Brittany Barber Alexander and Paul Kalkbrenner. So we're very glad that you all could join us today. Thank you.
All right, welcome. We also have Sean Bear, and Sean is on the line, I think. And Sean's the Assistant Director of the ATTC. Welcome, Sean.
Hello, I'm Sean Bear. I'm from the Meskwaki, Edmonton, Iowa. I'm actually the co-director of the National Academy and Alaska Native TTCs. Nice to meet you.
Okay, we can get going now on our process, and I think we want to leave minutes or time at the end for question and answer, and there may be questions for the panel members. So I think you have an order you're going to go in. So who's first? I don't remember the order. Sorry. Is it Jared? Yes.
Yeah.
Okay, Jared.
I think I kind of went into it when I was supposed to just do introduction. I mean, I could repeat it again and bore everybody, but also, I think we're half an hour in. So if Colin would like to come in and say some words and get everybody excited again, and then we'll go to the next panelist, huh?
All right, be good.
All right. Thank you.
Colin.
Okay, so there's two vital elements that I believe are critical to peer support. And one of them is demonstration, to demonstrate what recovery looks like to people that are initiating the journey or in the journey, demonstrate different pathways of the journey. And then also there is a second element that I believe is critically important, and then that is to give credibility to the services wherever they're working or being provided. So what I mean by that, so like we'll start with demonstration. The biggest component that happened to me in my recovery when I was in inpatient treatment, 30 days, I'm only a couple weeks into my journey. I had a cousin, my first cousin, my brother, that I used to take baths with, and he used to get the water all gray. But anyways, he him and I have similar backgrounds, coming from a lot of trauma, juvenile centers, and prisons. So we have a colorful past. And I was sitting in treatment and I was super insecure over the journey that was ahead of me. And I felt alone and I was afraid. And my cousin came in to do sweat lodge for the treatment center that I was in. And I was in such shock and awe that somebody with my similar story, background, and everything is in recovery and practicing the culture element of it, well, it's a spirituality. And he was so confident in the way that he carried himself. He was so confident about his recovery. He ran the sweat ceremony for us that were in treatment. And I was such in awe by him because I didn't know he was in recovery or his journey. And it reminds me of the story of Roger Bannister. So prior to 1954, they believed that it was physically impossible for the human body to run a mile in 4 minutes. They said, scientists were like, nope, it's just not possible. Nobody can do it. And then in 1954, Roger Bannister did it. And every single professional athlete after him kept doing it since. So it's always impossible until it's done. And so what my cousin did for me that day, while I was inpatient, scared, insecure, timid about my recovery, he came in and he demonstrated a 4-minute mile for me. This was somebody that I love and that I trust, and and so when he did that for me, it didn't matter what he said or what he did, he just ran that 4-minute mile. And so that was pivotal. And then also giving credibility to a lot of the organizations that work within reservations. There was data from, I think it was like 2010. It's old data. I don't know how accurate it is today, but 80% of HHS is non-native. And so you incorporate historical trauma and all these programs and all this stuff, and you're taking community members or relatives from the community in there, and you're trying to educate and advocate and provide services for them. They're not going to trust what you know what I mean? There's that hesitancy or that lack of trust in the process and the organization. But if you had a peer support there, somebody that looks like them, that is from the community, that is running a 4-minute mile, that is advocating for the services, the person, the relative that's receiving care then has trust in the process, has trust in the organization, has trust in the modality or whatever it is that where the peer is employed. So those are two vital components that I believe are fundamentally significant to peer support. And it's kind of reminds me of a story. The person that trained me to be a peer, her name is Chris Kelly. She said that she went to the dentist one time and she had an ache on her tooth, and the dentist came in, did the normal check, and walked out, and the nurse come in, and she felt more comfortable talking to the nurse to say, hey, I got an ache in my tooth, than speaking to the dentist. And so like that nurse was able to say, okay, and relay that information to the dentist. And so like sometimes peers, you know, like with that lack of trust and you know, being in proximity to people that are in recovery, running that 4-minute mile, so to speak, can really improve outcomes, attendance. And there's just so much evidence that backs up what peer support can do. And not only that, but like it bleeds into the community. So if you're looking for solutions to this drug epidemic, why not talk to people that have done it? And so like people in recovery are the most underutilized resource and the most valuable resource when it comes to combating this drug epidemic, is other people that are in recovery because of the passion and the drive, that 4-minute mile, demonstrating to people what recovery looks like. So so the people that are curious feel more comfortable along with their journey. And so like those are some things that I believe, I don't know how much time I have. Hopefully I dropped little nuggets in there for you guys to utilize or take with you. But I will say this, in Minnesota here, 5 years ago, there wasn't a whole lot of peers that were working throughout the state. And now with the incorporation of peer support on all these other reservations, I have seen recovery communities or little support groups of people emerge in these diverse communities that can sometimes be, like recovery hostile or whatever, however you want to word it, with a lot of disparities. And so so like I fully stand behind peer support. I advocate for it, and it gives community members, stakeholders, members the opportunity to give credibility to organizations, and they know resources in the area because they've obviously navigated those. And when you have somebody walking beside you to help navigate resources that say, hey, I've been here, this is what I've gone through this. It just helps the relative that's receiving care trust the process, trust what they're going through, so yeah.
Very good. Miigwech. Okay, is it Eric next or Annette?
I'm not sure, but I can go.
Okay.
Again, my name is Eric Martin, and we do the certification for addiction peers in the state of Oregon, along with Oregon Health Authority. And at the end of this training, I want to be able to answer any questions that you might have about peer certification. We did a national analysis of peer certification some years back, so I had to familiarize myself with state administrative rules for just about every state in America when it comes to certification requirements. That was a little bit older, but I think some of the issues tend to be the same state to state. So we also operate a technical assistance center, and we provide best practice trainings to peers. And the last several years have been a great opportunity to be able to dedicate the entirety of our funding for technical assistance to BIPOC institutions. So I've always tried to work closely with BIPOC institutions as a person of Latinx descent and co-founder of the Northwest Instituto Latino here in the Northwestern United States. I've always had sort of a dedication to BIPOC organizations, and fortunately right now has been a good time to dedicate all of our resources to BIPOC peer organizations under our current grant. And we've been able to make great headway in health disparity. Now, as I was previously saying, there's two types of peer, freestanding peer organizations. There is recovery community organizations, or RCOs, and these are organizations that employ peers and they provide peer services in the community. And then there are RCOs that also offer recovery community centers. And a recovery community center is similar to what many of us have known in the past as like 12-step clubs, mental health living rooms, drop-in centers. And these are centers where people in recovery in the community can come. And what's great about these centers is that they really capitalize on volunteerism, the volunteerism of other people in recovery that Colin essentially talked about and Jared talked about. And, treatment centers have long tried to capitalize on this volunteerism through alumni programs. And alumni programs have been kind of hit and miss at treatment centers over the years. They'll like one year they'll have a great, sort of rock and roll alumni program going where alumni will help new people coming out of treatment get connected to the recovery community at large. And then the next year, for whatever reason, the alumni program's not doing so good. And there's not a lot of people volunteering to do that in affiliation with treatment centers. So this sort of overcomes that problem of alumni programs that ebb and flow at treatment centers. Community recovery centers, they have all these meetings that they support, like 12-step meetings, Wellbriety, Refuge Recovery, Smart Recovery, Life Rings, stuff like that. And they host these meetings, but at the same time, they have professional peer services. They have certified peers that work there that provide services like helping people find jobs, having an awareness of felony-friendly employers, employers that will hire people that have felonies, housing information and referral, social activities above and beyond just recovery meetings. And more research is coming out from the Recovery Research Institute that really carries a lot of implications for the practices at community recovery centers. We know that peer services work. There have been two large systematic reviews. One, a 17-year systematic review that looked at research between 1995 and 2012, and an 8-year systematic review that was published in 2016 that looked at research between 2005 and 2013. And both of these systematic reviews showed that peer services improve the outcomes of people going through treatment. So we know that peer services work, and we know that people that if we can leverage the volunteerism of people who are in recovery to help new people coming through treatment and out of treatment, that we are going to improve outcomes dramatically. And with a bigger focus on BIPOC community recovery organizations and community recovery centers, we can finally address healthcare disparity in this country. So if you have any questions, as we head towards the end of this, about certification or best practice training, I will try to answer those questions. Thank
So
you.
Eric, since you're still talking and you're the guy that trains people in the state of Oregon, what are some of the basic criteria to become a peer support specialist?
Okay, that's a great question. So in the state of Oregon, there's a basic 40-hour training that people have to do in order to become a certified addiction peer or SUD peer, substance use disorder peer. And that 40-hour training has a lot of different elements in it, like the SAMHSA wellness factors and motivational interviewing and suicide intervention and prevention and many pathways to recovery, medication-assisted treatment. So there's a lot of basic information in there that people that work in social services and in peer services need to know about. However, when we look nationwide, generally training ranges between anywhere from 40 hours all the way up to 120 hours from state to state. So some states require less, some states require a little bit more. And in it also, some states will require an exam, either a homemade exam or an exam produced by the ICRC or Mental Health America. So it just varies from state to state, the basic requirements, but they're somewhat similar.
Okay, great. So if there are people in the audience who have questions or else need additional resources, I wrote down the one in the chat that's asking about Arizona. And I have no clue about Arizona, but I will certainly help somebody to find out about Arizona. Okay, Annette.
Do we have a question or are we just
Yes,
chatting?
here's the question. What would be a recommendation for you for building a peer recovery program in their community, in a tribal or urban community?
My recommendation, I've seen a lot of, we tried to do within our agency, tried to build like a peer support program and within like our MAT, and I can say that it didn't stick. And for a few different reasons, but we do have peer support agencies in Alaska that are very successful. And that's all that, they're kind of in-housed. There's some in Anchorage. I believe there's a couple in Fairbanks too. So I don't really have, this is a hard question for me to answer because I don't have any experience with it. So yeah, I don't know.
Well, so I would ask a question, and thank you, Eric, for providing the resource in the chat.
He did great.
He's
Eric did
really-
great. Eric, I was like, oh, Eric just answered that question. So yeah.
So I have another question then. What, based on your own, and I think you answered some of this earlier, based on your own process, your own recovery, what does peer services, support services look like to you? And what has worked?
What has worked is honest conversations with people getting services, and so I work in MAT, right? Like I directly deal with patients in their medical care. Something that Eric was talking about health disparities too, right? So as somebody so I was a medication seeker, like I got all my drugs through a doctor. And I work with patients who do the same thing. And so I talk to patients straight up and I'm like, all right, we know that we can use medications as drugs and we know that we use drugs as medications. And they're like, and people are like, yeah, I had no idea. And I'm like, all right. So when we're talking about MAT and buprenorphine and things like that, we're having, my job is to have those conversations with patients, having honest conversations with people like we do as peers, period, end of story. Like, hey, your medication count is off, or hey, you're about to lose your housing, right? Like, because we know these things, because like Jared was saying and Colin was saying, like, these are our relatives, these are people that we know, we're a small community. Not being afraid to do this stuff, but it also means that we have to do the work. And so sometimes when I'm working with somebody, my own stuff gets triggered. And so I have to not be afraid to do the work. And I had some stuff come up recently. I had to go to counseling, and guess what? I'm not afraid to tell people that either. And then also, because I've had struggles with like, how do I talk with patients about why they need to go, right? Or what the benefits are of counseling. And so not being afraid to have honest conversations with people when we see that there's that they might be headed down a way, because I work with people who aren't accessing support groups, and so the only time that they get support is when they come to the clinic. So our job sometimes is to point them in the directions of support. And so we have to not be afraid to tell them, like, hey, your diabetes is up and you're not taking care of it, and because you're using drugs again or whichever. You got to have that conversation, or appropriately, saying, if you can't do this, here's a Narcan kit, and, having that conversation as well.
So what have you encountered utilizing cultural programming in your work?
We've done a lot of like fishing days, because that's a big cultural component down here where we're at. Is we have an educational fishery net. And so we had set up some educational fishery days, and had, done a bunch of flyers with that. One of the things that was extremely, so I had a practicum project for my work, or for my schooling, and had gotten some active users together. This was a while ago, so it's probably 2017 or 18. And that was a support group for people who are still actively using and had done education. So we had done a peer group during that time. So we do a lot of like connection. Food is a big one, and getting people together. So fishing and just a lot of gatherings, which we haven't been able to do, of course, but those are the things that keep us together. Connection. It's a very, being connected to each other.
So have you connected virtually throughout the pandemic?
No, but we do have COVID protocols and our clinic has remained opened. So we've been able to see patients and remained connected. And then we also have people who still come to other outreach events. And so we've been able to remain with social distancing or doing telemed. We've kept open for telemed too.
Awesome. So any of the other panel members, would you like to take a stab at the cultural issue? Either Jared or, I know Jared has talked about doing the sweats. And then is there anything else culturally that either one of you have utilized in your work?
So basically, we let the community, because we have 9 different tribes. So we have Longhouse people, we have people from South Dakota that come to NARA. So NARA is clinical treatment, and NARA saved my life. NARA is amazing, right? Culturally specific treatment. So when they come to NARA, after they leave NARA, we pick up that continuum of care. So basically, we let those have a safe place to reconnect and do their singing, do their drumming, do their culture here. So others in that area that are a part of that band or a part of that clan can come in and sit in on that, and, eventually, it would be nice to get some land, to put up a lodge and to put up a teepee and grow our own medicines and have those horses for that equine therapy, that connection, to those 4-leggeds and really work through that way. Are we there yet? No. We're doing services. We're getting ready to open in 2 weeks, but yes, just offering a safe place to reconnect to culture and community. So, I think culture, without culture as native people, we struggle with your general dominant culture way of staying clean, right? And I hope that doesn't offend anybody, but that's just, from what I've heard and being walking with, other people in the Native community, that, that culture gives us that sense of belonging. It brings us home, so to speak, and it makes us feel like, we're where we need to be, so, but if specifically, once we get that land, we'll be able to do more as far as the culture, but just offering that safe space right now for people to, to drum, to sing, to, pray in the way that they pray, and just having that safe space, that drop-in center for them to be able to do that, but we have the medicines here, they're donated and we're able to give community members medicine and stuff like that. But as far as building that out, that's in the near future. So thank you, Shirley.
That's great. So the other thing too is I know I have a grantee from another grant that I do, and they're doing equine therapy, and it's working so well, especially with the children, because they said that a lot of the kids, especially in the beginning, they won't even talk. So when they don't talk, they connect with the horses, and it's kind of like they develop that attachment to the horses. And then they use sometimes those little bitty horses. So they work with the kids, and they're almost like similar in size. So it's really awesome, the work that they're doing with the kids, and the horses. And they want to be able to replicate that, to other tribes and share that, because that's something that's working really well with that tribe. So that's really cool. So good luck with getting your land and getting your additional programming that you'll be having. I know it'll happen.
Thank you,
Colin,
Sean.
do you have anything else to add on the cultural piece?
Not everybody may be ready for recovery but everybody was always willing to learn the culture. And within the culture, there's just so many tools to utilize to manage, whether it's like manage stress or learn self-discipline, service, respect, integrity. There's just so many values that are packed into the culture that is like the great equalizer. Not everybody's going to be willing to engage in a 12-step meeting or to even talk about recovery. Maybe they're not ready for any of any of them steps, but almost everybody is willing to participate in the culture. There's, I don't know, like I want to say like this might get me in trouble a little bit. And I kind of want to unpack a saying that I love. Where we're told to out of respect for our medicines to stay away from them when we're using. And to me, the way I understand it, the way that I smudge and the way that I utilize the medicines and how much they help me, why are we keeping our medicines away from our people that need it the most? And so like I like to you know what I mean? To sit and smudge with a lot of people. Like when there was per cap patrol here, when everybody got their per cap payments, we would set up in front of the market, and all I did all day long was just walk around and smudge people. Like, hey, how you doing? What's up? And I would smudge them, or they'd want to smudge themselves. And to me, that is building that initial contact, or building that initial connection, building connections. So that way, whenever they're ready to take them next steps in their recovery or whatever, they know me, they trust me, and it's just, I don't know, like there's just so many tools and philosophies to unpack with the culture that could be utilized in recovery that people relate to on a deeper fundamental level than, that I've seen versus where I've seen anywhere else. So yeah, I just want to add that.
I can totally understand why you say you could get in trouble, because there's I'll attempt to explain part of it, because I encountered the very strict abstinent community back in the 90s when I first started on my path. And they are very strict. You cannot do anything. You have to make sure you're haven't touched anything or been around any substances for, I just say 4 days. That I'm just throwing it out there. I don't even remember. But if they say for 4 days, you have to be totally substance free. And you can't smudge, you can't go to sweats, you can't go to Sundance, you can't go to any kind of ceremonies for 4 days until you're like totally, it's out of your system. And I think with the more recent recovery people, it's been like they want to be able to utilize it with people that are actively using. So to help the process of healing. And it's also, to me, it's like a kind of down the path of the harm reduction model of not judging, not judging people that are actively using, because they're still like Colin and Jared, and I know Annette says this too, they're still all of our relatives, no matter what way you slice it. Even though they're from different tribes, they're our relatives. And we always love our relatives, no matter what. The substances took them down a different path, but that doesn't mean they're bad people. They just are on a different path for now. And then we keep praying that they'll come back to our path and join us on this road. But if they don't, we still do whatever we can to help them and to support them. Did I say it correctly, Colin? I don't know if I phrased it the right way.
I would like to add something too, if that's okay, Shirley. I believe, that the medicine takes care of itself. and those, like Colin said, he was going around smudging people no matter where they were at, you know, and Sober Squad has gotten really big, you know, and it's really helped people. So that medicine is taking care of itself, you know, like, if that makes sense to me, like that's, you know, he's utilizing that medicine in a good way. So it's taking care of him and the people that, you know, he's taking care of. So, and I think, you know, we all have views and, you know, and everything has politics around it, your ceremonies, your sun dances, you're right. But at the end of the day, in your sweat lodges, you go in, well, first round, I'm going to call the spirits in, and the second round, I'm going to, you know, but like, you know, like it, but like once we let our humanistic, like controlling thing go, like the medicine just carries itself, and, you know, creator just puts it the way that it's supposed to be. So, I don't know where that came from. I just felt like I had to say that. So, you know, sorry for just getting real indigenous on you guys, Shirley and Colin, but
That's okay. So Kate, how are we doing on time?
We have another half an hour yet, so we've got plenty of time for discussion if people have questions. Yeah, if others want to ask questions of our panel, please jump in.
Yes, just unmute and ask your question.
Actually, maybe raise your hand. Use the raise your
Okay.
hand feature on the reactions button.
Yeah, I'm not the raising hand type. I just jump in usually. I'm kind of old school.
Surely.
Are there any questions?
Yeah, I have a question. My name is Jesse. I'm from the Cow Creek tribe. And I was a question for maybe Eric, I'm sure he knows. Is there a clean time requirement for a certified recovery mentor or a peer support specialist?
I think in most states, the answer to that would be no. So in Oregon, we have a recovery time requirement, which is different than a clean time requirement. So we want people to have lived experience.
Okay.
So we require that people have a minimum of 2 years of lived experience in recovery, but we don't have a specific abstinence time. So courts around the country have ruled that if you have a specific abstinence time, that could run afoul of the Americans with Disabilities Act. So we don't, you know, we wouldn't do that with a person like, say, with diabetes. You know, say, well, you can't have had any lapses in diabetes that required hospitalization in the last 2 years in order to be certified or employed, you know, for whatever job. So you couldn't really do that with somebody with any sort of healthcare disorder. So most of us in this room have long advocated for addiction to be considered a healthcare disorder versus a criminal justice disorder. So, in doing so, in saying that it's a healthcare disorder, then that puts it in league with all other healthcare disorders. So, generally speaking, Jesse, across the United States, you can't really have a minimum abstinence time requirement for credentials for certification and employment in the U.S. That's a great question.
All right, thank you for the clarification.
They
I might-
have,
Oh,
go ahead.
I want to maybe speak about that. So, I mean, through our services, right, we have MAT, peer support, or MAT and behavioral health, and some outreach stuff at our agency, right? And I will tell you that they are our number one referral stuff. We don't even have to go out into the community and say, hey, we're open for business. They all just refer people. Yesterday, I had one patient refer 4 people, okay? And nothing would make me happier than to employ that patient or give him a stipend, right? Give him a stipend, give him a $30 stipend, okay? Because how cool is that? This guy got a Sublocade injection last week and has not used opiates in a week. That is the longest he's ever gone, and referred 4 people to our clinic yesterday. And I cannot give him a stipend or employ him or anything because he can't pass a drug test, because that's an agency thing. And I'm going to tell you, we know, because it's evidence-based, because there's scientific data, that people who use drugs are like the #1 peer support, right? And so when we go back to this agency and peer support, right, like they're out, like it's our job per se to educate these guys about safe injection practices, MAT, where to get services, all that stuff. That's what Jared, that's what Colin, that's what Eric's doing. That's what we're all doing, is we're providing these guys these tools to help them be safe, right? And then they go out there and they talk to each other and they tell like, hey, I was at the clinic and I got this educational tool and I was learning all these things. And we can't help them or provide them with jobs. And then, I don't know, I'm kind of going to go on this rant. I'm really sorry, but we can't provide them with an employment at our agency, even though we're watching their lives get better, right? They're not using opiates, or they're not using stimulants, or they're not drinking alcohol every day or anything, because they can't pass a drug test. But their lives are getting better and they want to help their peers through behavioral health or through the medical or anything like that. But this is an agency blocker.
Annette, I'm not sure I understand what you're saying. You're saying the person is not using illicit drugs, that if they take a UA, they'll test positive for Sublocade, and because they test positive for Sublocade, they're not eligible for employment.
No, they test positive. They might test positive for like a stimulant. And so if we were able to like give them like a stipend, right? Like like a referral thing, right? Like, but you can't do that because it would put them on their like employment record. So when you're looking at hiring somebody for peer support, does that, like if there was like something like Jesse had just mentioned, right? Like some kind of backdoor way, because these guys are wanting to be peer support. Like when you're offering a low threshold or a harm reduction model, right? If you had that harm reduction model through your clinic, or if you had like some kind of certification, right? If that was your model that you were doing and you had like, hey, we have 5 harm reduction peer support people, and they were quote unquote like exempt or something, right? And or like some kind of stipend, so that you would be able to help more people, because people who are trying to access harm reduction through your agency aren't going to listen to somebody who's abstinent only. That's a really hard thing. That's a really hard thing for people. And that's like where we're in this world. And maybe that's just my community that I'm talking about, but that's just something that I see a lot of. Abstinent-based people in recovery talking to people who are harm reduction only. And it's just this ongoing barrier.
Yeah. Thank you, Annette. I think too, like sometimes in our community, you have, people that have been drinking 30 and 40 years, right? And, even if you get them housing, no matter what you do, they choose to, geez, that thing's shining. No matter what they do, no matter what you do to support them, a lot of times they choose to go back out, and if they're connected and able to stay connected, and they're just, smoking weed instead of drinking, and they've been drinking for 40 years, that harm reduction, and walking through that with them. Like, we're not there to judge people and their journey. We're just there to support them in their journey, no matter what that looks like. Right. So it's like, like take our judgments out of it, and it really cracks me up too. Like sometimes you'll go to an A or AA meeting and they'll be like, abstinence is abstinence and you have to be abstinent. But yet I think the thing about those is like, when you like, instead of judging the newcomer, open up your arms to the newcomer, right? And what does that look like? And then peer services too, being able to support people no matter where they're at. We're not there to judge them.
I think if peer support is done right, and they're trained right, you know what I mean? Peer support is not about the peer at all. That's one thing they ingrain. It's not about the peer in my journey. It's about what does the peer need to meet them where they're at. And maybe I just need food. I don't want recovery services. I just want food. Okay, well, you know what I mean? Like, let's look at some food shelves local to the area, or you know what I mean? Like, so if peer support is done right, you know what I mean? I do a lot of harm reduction services, and I've been for a long time or whatever. But me personally, I'm abstinence based. I haven't, you know what I mean? But I do a lot of work in the community because abstinent based people are only a small percentage of the community, and I want to help all my people, not just that small portion of people, you know what I mean? And so, like, in order for me to help all my community, I have to go into places where early on people would ridicule me for going or talking to people like, why are you talking to them? And you know what I mean? Like it's just, I want to be that lifeline. I want what I say all the time, buddy, like me, when I was in early and like harm reduction is a radical act of love, you know, and it's just, I think we need that in our community. But there was one little thing that I wanted to touch on about peer support. So like, there's been a lot of pushback from like LADCs and people that are working in a peer support, they're infringing on my me and like things like that. And I just wanted to demonstrate. So like what the peer support does in them situations is where they act as a hand of like a CD counselor or whoever, because like instead of the CD counselor dealing with somebody on making phone calls for housing, bringing them to court, or making calls for you know, like all these different reasons that a peer support could do to free up that time for the so that way the LADC could do their job instead of, you know what I mean, rides to court, rides to, you know, housing, you know, aftercare, setting up all these different things that would normally chew up a time of a CD counselor in them settings. This definitely, that's like, you know, because sometimes what I've heard is like, you've been to a training for 1 week and I went to school for years, you know, get out of my territory or my field or whatever, you know what I mean? But so like there's a stigma within the field for peers that work in them type of settings. And they're just like, go do a UA or something, you know what I mean? Like, get away from me, go do a UA, or, you know. But I just wanted to share that that peer support allows the CD counselor to do their job more effectively, not making them calls that you know could chew up a lot of time. So I just wanted to throw that in there because there's been some pushback about that as well.
Okay. Are there any other questions? Does anybody else have a question?
Is it okay to make a comment? And maybe
Absolutely.
they can respond to my comment.
Yes.
Kia ora na koutou. I should admit that my name is Ed Napi and I'm a member of the Ngāpuhi Iwi or Ngāpuhi tribe from Taitokerau district of Aotearoa, New Zealand, where I was born. And let me tell you, I love these meetings because they speak to me so closely to my heart, me being someone who comes from another country so far away, and I'm fortunate to walk on the land where the fires were kept alive by other people. And I work at the Sacred Circle Healthcare, which is owned and operated by the Confederated Tribes of the Goshute Reservation here in Utah. And, you know, MAT is central to our programs, as is peer support. And I know that our counselors like to create opportunities for the participants in our program to interact more with each other. In fact, they're building a whole floor so that they can do that. One of the methods that they use, of course, is is arts and crafts and other cultural activities. But I just wanted to broaden the scope a little, just because I'm thinking of the fact that my people and your people, all of your peoples, are in this predicament because of the ways in which our spirituality, our communities, our health, and our other activities have been affected by colonization. Our people have been affected like that too. Now, one thing that I've learned both from my adopted parents who lived on the Northern Ute Reservation here in Utah, and also when I think back on my own life experiences, is that in the Western way, there is only one choice. But in our way, there's not one choice. There's more than one choice, and they can be incorporated at the same time. For example, I was raised in a Christian family, right? And that's a whole nother story, isn't it? But at the same time, we were also raised with our stories and traditions, like stories of the Earth Mother and the Sky Father, who are essential to who we are, right? And then I found in my own experience and talking to my elders that, there can be more than one answer, okay? And then I learned that from my Ute mother, because I remember going back for Christmas, and at 8 o'clock on Christmas Eve, she would say, okay, we're going to the Episcopalian church for Mass, and we'd all go. Then we'd come home, and then at 12 o'clock, midnight, she would say, okay, we're going to the Catholic church for Mass, and we would go because they saw no conflict. And yet in the months of July and August, we were up at the Sundance. And so they chose not to let those things create those conflicts in their lives. And I think when you give a person only one choice, then they might have more difficulty. But if they have many choices, and sometimes choices are equally good, maybe they feel a little bit more comfortable. That's my way of seeing in the world. And I'm sorry, but my point of view is still very narrow, even though I tried to broaden the perspectives. And that's all I have to say for now.
Okay, thank you. Thank you for your words. And that's a really beautiful perception, right? So, and I'm definitely in agreement with, some of the things that you spoke on. And I think that's the beautiful thing about an RCO, and a culturally specific RCO, is we're able to keep it rooted in tradition. If it's non-clinical and it's community, it's ours. So, and being able to build what that looks like from our elders. We have some, I don't know if you guys know, like Kathy Archambault and Deborah Buffalo, but our elders have been, through a lot of places. And it's not my place to say, what ceremonies they went to, or I'm not going to say what ceremonies I went to. I was taught, to just be, that way anyway. So, and learning and listening. I think the key is listening to our elders and them creating that space, so then we could listen and create that with what we need to do. So we can get, the data to continue to get the funding to continue helping people. But really, I think the thing is too, so if we have people that want to do drum tie, whatever, we create that space and let them do that. And even, if it doesn't align with my beliefs, it doesn't matter, right? So we're just here to create a safe place and support, right? So even if some natives come in with, and want to start a Bible meeting at our center, right? And that's what keeps them, that's their pathway. Like, we support that, right? And I like what Colin said earlier, I don't know if he said utilizing MI, but using MI, even though, I'm absent space or whatever, and asking them like, hey, what does this look like? What would this look like if this was different and you use this? You know what I mean? Like, using that MI to help them navigate their own thought, because it's a lot easier when they come up with it. They're like, oh, that's a great idea. I can't believe I just came up with this, and figuring that out and moving through it on that, So, but yeah, I just wanted to say that. Thank you.
Big glitch, both of you. I understand we have two hands raised. I'll go with the virtual hand.
Hi, I'm Sia Cooney. I'm from Fairbanks, Alaska. My family is also from Pine Ridge Reservation. And my mom is from Alaska. So I'm a mixture of a lot of things. I work with youth, and I have worked with youth as far as I can remember, and of all ages, from Head Start to high school now. And I said I'd never go to Head Start, and I said I'd never go to high school, and I'm in high school again. So my youth here and my youth that I worked with in Anchorage at Romig, they always came to me to dump on me, basically, because I just apparently attract dumping. And I'm there to listen. They're comfortable with talking to me, probably because I'm Native and maybe because of my energy. I have no idea. But my thing is I want them to be more peer-to-peer support for each other, because I'm not going to be around for the rest of their lives, and they need to start doing this at a younger age. Granted, to me, it seems like I've had great peers in my life, so we've always had peer-to-peer support in everything that I've gone through, whether that be breakups, suicide attempts, drinking, alcohol. We never touched on those things. And I think a lot of kids need to hear that other kids are going through the same thing, or from an adult perspective, that my life hasn't been easy either. And your parents might be going through some changes also, but they're not yet there to change. So to help them understand. So it's just, I think just communication in general, what peer-to-peer is communication and being comfortable with the person. We just got a grant and to hire an expert person here. However, to me, it has to be a fit role person to do that. And the kid is just not going to fill out the expert because they know it's something that's connected to the system. So to me, I don't know, the system hurts a lot of our kids in so many different ways, and they're afraid to talk, and they're afraid to come unglued. And they need to be the cycle changers is basically what I see them as. So that's why I'm in this position, and it's under a juvenile justice department. So I love my job here, and I get to work with Native students and non-Native students. So thank you.
I did put some resources in the chat for you, and anybody who wants them.
Okay, thank you.
Thank
Yes.
you.
My name is Doug Whittle, and I'm originally from Cheyenne River. I'm down here in Santee, Nebraska. Down here, what I teach down here is the Teoshpai concept. And we utilize horses and sweat lots, talking circles. I run a IOP group here, but it's run culturally. And when we use the horses, I mean, there's a clinical psychologist that comes here probably once a week or once a month or once every 3 months or whatever. I could do 9 relatives within that hour, and this clinical supervisor or clinical psychologist won't even be able to do 1. So these horses, they're awesome. They're healers too. And so if we open up that part, and what we do here is when they're ready, we'll call their nari back, we'll call their spirit back. And then from there, we go through the codependency piece too. And from there, they're off doing their own ceremony. And so, but it's really hard to teach using the horses, because you have to work on yourself. I've been sober for 32 years, and still working on myself every day. And with this program we started here, you know, at first, you know, they're making fun and all that kind of stuff, but we kept at it. And right now we probably have like 8 or 9 that are sober. And that's better than the national average. And so I apologize for getting on late. I run a language class too. And so it's great that you guys are doing this, you know, coming together and helping each other. And thanks for letting me speak for a little bit. I kind of came in at the tail end. But yeah, we utilize horses and that Teoshpai concept and bringing that back to the people. And I said, if you want to change, you know, don't run for council. I said, you as a people can change the community by helping each other. What they used to say is love each other and help each other. Oh, that's it too.
Douglas, are you saying the only thing you can change if you run for council is your wallet and your bank account? Is that what I heard?
The only thing you can change is yourself.
Hey, yeah, good answer. Good answer. Thank you, Douglas.
Thank you so much, Douglas. I really appreciate your words. They're really some good words. And also what I've seen too across the country is we really need some like really positive role models in some of our leadership positions. Because, you know, if our leaders expect our people to be, you know, walk in a good way, you know, walking in a healthy way, they also need to be doing that too. And I'm not saying this to be judgmental. I'm saying it because that's what our people need right now, because we have such a high rate of natives that are overdosing and dying right now. And it makes my heart really sad to see that, you know, because I can look at even my own website, my tribal website, and it's not just natives from my own tribe, but natives from a lot of other tribes that I know are overdosing. And we have to do what we can to help to stop that epidemic from happening. Okay, are there any other questions from the audience? No?
Hey, everyone, it's Paul from Samsung, latest addition to the TOR program, pushing in long-term recovery. Sobriety is March of 1988, and I'm also a PRS here in Virginia. So I look forward to working with many of you. This has been real informative. Got lots of questions, a lot of things I'd like to discuss, but this is for you, but I just wanted to chime in and thank you all for being here, and look forward to working with you.
Thank you for that introduction and for chiming in. As we only have a few minutes left, I wanted to ask if the panelists would put their emails or their contact information in the chat, if you feel comfortable doing so, because I know people might be interested in connecting and you all have so much knowledge and experience. And I just want to thank you again from our team, from the Native Center for Behavioral Health, and the TOR program, the TOR TA project, for taking the time to be with us today and speak about your experiences and your expertise. I know I value it a lot, and I'm sure everyone else does.
Everybody, thank you for coming and being on part of this panel and just coming in and listening. It feels really good. My heart feels really good. So just thank you. And Shirley, if you have anything to say, because, oh man, I knew he was going to unmute that guy. All right, go ahead, Colin.
No, I just want to leave everybody with a thought or a saying that I fully believe, and that all of our answers are already in the community, you know, but we just have to find them, lift them up. And there's, you know, like everything we need is within our tribe. You know, and I just want to leave that thought with everybody that works on a reservation or near a reservation or works with natives. You know what I mean? We have all the things we need to succeed. We just need to utilize them and lift them up and give people the opportunity and hire and promote. Like I said, 80% of HHS back in 2010 was non-native. And so in order for us to trust the system, we have to see somebody that looks like us. So, you know what I mean? I would say actively search out, train, educate, give opportunities to natives to work within the health and human services field, pay them, give them a raise, do everything.
You know what? I would just add one thing. I had a meeting a couple days ago with a gentleman. He works with the different communities dealing with law enforcement. And I think what they're talking about is deflection, which is to keep people out of the system, the justice system, because we have so many natives that are in jail and prisons. And so to be a part of that process, I think would be really positive too. So our people, we get them out of the system rather than going in, because once they go in, they have that whole, background that they have to deal with, as far as housing and jobs and everything. So I just wanted to throw that in.
Remember your values, remember who you are, your core truths as a peer.
Right on. Okay, Miigwech, Julie. You're probably my relative.
And one thing that has nothing to do with peer services, if you're a parent, you're a father or a mother or a grandmother, just take that time to sit with our young ones and our youth and our future, because just validated or that connection and that talking, it's easier to grow young warriors than to fix broken men. But we're supporting them in peer recovery, if the ones that struggle and have had struggle with addiction and stuff like that. Like, that's what we're here for. Peer services, right? We help them walk through it. And I had to bring it back around to peer services, but I mean, really in the beginning though, it's just easier to just build young warriors, so thank you.
Talking about heart, Jared, stop.
Just trying to impress Colin.
Whatever. Okay,
Thank you
everybody,
all. Thank you so much.
passed the hour.
Have a wonderful day.
Yes, Miigwech, everybody. Miigwech. Later on.